Yeah, my name is Cheryl Ho. I'm a physician, so I'm a medical doctor, and I was the one of the original co-founders of the Valley Homeless Healthcare Program, which is the largest healthcare for the homeless program in the county of Santa Clara, which geographically encompasses as far north as Palo Alto, as far south as the farming communities of Gilroy, and all the cities in between, including Mountain View, Sunnyvale, and most notably San Jose as one of them. So I was the original, one of the original co-founders of that healthcare organization for folks experiencing homelessness with the County of Santa Clara. And I'm also the CEO of Healing Grove Health Center, a faith-based healthcare organization in San Jose. And I'm also affiliated with Stanford University as a affiliated clinical member of the School of Medicine.
So based on your experience, because you treat homeless individuals all the time, that's what you do, like based on your observation, like what's the prevalence of mental illness and drug addiction among this population?
So I think I have to maybe first step back and clarify. I think the folks that I've seen in my nearly almost 20 years of practice have primarily been those that are considered chronically homeless. So folks that have been on the streets for more than 1 year, and are not episodically homeless. And so, I just want to clarify when I kind of state that. But so out of the folks that I see who are primarily chronically homeless individuals, I would say the vast majority, close to 90% and above, suffer some sort of severe mental illness, as well as some sort of history of some sort of substance use disorder, and as well as severe history of trauma.
Wow. So like when people hear severe, like what does that mean in terms of severe mental illness?
So, in terms of severe mental illness, I think clinically they're compartmentalized into what's called Axis 1 and Axis 2 disorders, or, I think there's the, DSM manual. And so when I say the word severe mental illness, I'm really referring to Axis 1 disorders. And so, this could range to anything from recurrent depressive disorder, generalized anxiety disorder, to some of the more serious thought disorders, such as schizophrenia or schizoaffective disorder, bipolar disorder.
I see. And I noticed when you mentioned the prevalence, you're sort of like grouping the two together. So is that very common to have this kind of dual diagnosis among homeless, the unsheltered or chronically homeless population?
Right. So I think that the prevalence of both substance use and mental health disorder, especially in folks experiencing homelessness, is quite intricately intertwined. And so it's really not easy for me to say, which came first, substance use or mental illness, or at the same time. I think it's quite difficult to piece apart. Many times substance use, when you're living on the streets, it can be used as survival. Or many times, you grew up in a home where it was just prevalent. So it's really hard to say and to kind of pull those apart at times.
Why do you say it's for survival? I'm just curious.
Yeah, I think, if you go into some of the different encampments, there is a unique set of social interactions that take place. I think that there are all these interpersonal and social, sociologic dynamics that take place that are really quite eye-opening when you really get in there and meet the folks and really talk to them. And sometimes, for example, in order to stay awake at night. So, one common theme that I hear for folks staying in their cars is that in order to stay awake, because it's quite easy to be a victim of violence, when you're sleeping outside, is they really cannot go into deep sleep. And if they were to go into deep sleep, then they could be physically assaulted, sexually assaulted. Many people are robbed. And so people often will use illicit substances, such as different stimulants like methamphetamines, to stay awake at night, just so that they won't be victims of theft or personal violence. Other, examples of kind of that as a survival is, in the heart of some of these encampments, really exchange or kind of um, the currency by which things are done are often by drugs. And so you often have to participate in order, perhaps in exchange for your own safety. I see that a lot with women experiencing homelessness. Safety is a huge component of their survival. And so often they have to do things that they normally wouldn't do just by sheer need to stay alive.
I see. So, I mean, especially for women, this is the sleeping on the street is extremely harsh, right? And so a natural question a lot of people ask is, we have shelters. Why don't they go to shelters? Do you know why?
Yeah, I think one of the sort of newer frameworks that I think that many of us in homeless healthcare are really thinking about housing and shelter provision is really kind of the concept of really trauma-informed housing or trauma-informed care. And for anyone who's been inside a shelter, you have masses of people all in your space. Definitely not a safe place to keep belongings. Shelters often may have certain rules of engagement. People have sometimes pets, or some are single gender, and some people are really triggered in their own trauma by the people that are around them. And I think also, just in terms of kind of from a medical health perspective, just look at COVID. A shelter was a terrible place to be, in the middle of the COVID pandemic, because the virus would be flying around in the room. And quite honestly, you were probably safer from COVID by sleeping outside. So for a myriad of reasons, shelter is not a one-size-fit-all approach for everyone. Obviously, for some, shelters are extremely helpful, and they've helped get some folks back on their feet. But it would be hard-pressed to say that everyone would benefit from a shelter.
I see. Thank you. So just based on your observation, like, do you know roughly the prevalence of people who are on the street, homeless population who need some kind of treatment or medical intervention, but are not getting it?
I think I would ask perhaps I would ask you the question. I think when you say medical intervention, do you mean, does that include treatment for mental illness? Or...
Yeah, since it's hard to divide the two groups, right? Just maybe we can just talk about among people who are chronically homeless. And chronically homeless, by definition, they have some kind of disability / substance abuse disorder / mental illness. So, they already have some medical condition. So among that population, if they need treatment, like what percentage of them are not getting it?
Yeah,
maybe a hard question.
In terms of my opinion, my belief is that 100% of folks experiencing chronically homeless are in need of medical treatment. And when I say medical treatment, I mean 100% of people being on the streets have experienced some sort of trauma and do need support, whether it be psychological support, medical support, community support. 100% of them need some sort of treatment, and it's 100% unmet. Obviously we do, in my line of work, we do try to provide that on some level, but I have to be honest. We are only barely touching the surface with our interactions with folks. If you just think about professionals, many of who are probably watching your video, these are folks who, were in the pandemic and for the most part physically, remained unscathed during the COVID pandemic. But if you think about and kind of are aware of the mental health crisis that's happening even in well-off populations, it's absolutely devastating. And so can you even imagine people who've experienced trauma every day of their life, how much more mental health support will folks need? So wow. 100%.
100% needed, but 100% unmet. That's,
yeah, I think, obviously there are services that are out there, but,
right.
In no way are we 100% meeting the need. Absolutely not.
Yeah, that's staggering. That's, for people who need, I don't know, like for people who need some kind of treatment, like especially for drug treatment, some people may say, oh, they need to be ready before you can provide the treatment. And then some people, when they are ready, then they find it difficult to access the treatment. So could you maybe walk us through some of the main barriers for homeless individuals to access treatment, whether it's for drug treatment or for mental illness treatment?
Right. I think that I can mostly speak out of sort of experience from Santa Clara County. So I don't know exactly what it is for the rest of the country. I suspect it's probably very similar based on sort of my networks throughout the country with homeless healthcare providers. But, I think my impression of kind of the biggest need is the need for same day access to treatment. So basically treatment available the day you need it at the time you need it. And that is what I see as one of the one of the hugest gaps in care right now for folks trying to get out of, whether it be addiction or getting help for their mental health disorder.
So is it called like a treatment on demand, right?
Right. So treatment on demand, so I think, for example, if I want to say, I'm in the middle of my substance use disorder and I had, a big event that happened to me, perhaps it was the death of my family member or, a witnessed overdose. Oftentimes there are these kind of large events that kind of are the triggers for someone to all of a sudden go from not ready to ready. And I think the key thing, or whether it could be a hospitalization as well. And I think the key thing is when that person is ready, the system needs to be available for them at that moment, because there's really a small window of opportunity in which folks are ready. And if we miss that, I really think that we are at a loss to really help them at the time they're ready. And so you're absolutely right. It has to be patient driven. So when that person is ready, but I think we have gravely failed many by not being ready when they're ready.
So what is the status quo right now, like in terms of how long a patient needs to wait, or how difficult, or how many facilities are there? I don't know, like how many doctors are available to provide this kind of treatment?
Right. So, to be honest, I mean, a lot of the treatment modalities that are available and that could be helpful actually exist outside of the medical system. It's really more kind of with the drug kind of rehabilitation system. And so, so for example, in our county, in order to get for folks on Medi-Cal, which the presumption is the vast majority of folks, in California experiencing homelessness are on Medi-Cal or, Medi-Cal equivalent in the county. At least in our county, they are asked to call a 1-800 number. And so, they kind of, so step one, so let's just look at that part. Step one, you call a 100 number. Okay, so tell me, what could be some problems for folks that are experiencing homelessness? Well, you may don't have a phone, right? So I think step one right there is a flawed kind of just premise on how we think people should access the drug system, the drug recovery system. And so, if you don't have a phone, then there's a problem. How do you get in? And so a lot of people, I think, they're kind of named Obama phones. And so people can get these cheap phones these days. And so, you can get them at no cost and they're pretty easy to get. And so a fair number of folks have it, but the truth of the matter is that these phones are pay as you go. And so they're not like your typical AT&T or T-Mobile plan where, you pay $39.99 per month. You pay what you have. I mean, because many folks that are homeless don't have $39.99 a month to pay. So they're not going to have these unlimited minutes, so you're going to pay for your minutes when you get your check, which is often at the first of the month. So if you are wanting residential rehab at the end of the month, or hey, even at the beginning of the month, if you don't have the minutes to spend, you might not be able to make the phone call when you need it. So step one. So step two, say you have a phone. Okay. So you got a phone, you got a few minutes, you borrowed a friend's phone, whatever, you get on the phone. As soon as you get on the phone, sometimes there's a hold time, there's wait time. And if there's not, you get somebody, then you start doing an intake. And at that point, you tell them, who you are, your information, your insurance, your history of, use. And so to be honest, I think, and I've actually, because my patients notoriously have historically had a super hard time getting into programs that they need to get into, I will often use my time as a doctor sitting there in the exam room. So instead of, doing my regular doctorly stuff, I will sit in the exam room on the phone with them waiting. And so often I'll be privy to some of the information that I see happening. And so, I mean, they get transferred or, and so sometimes people get dropped in the middle of transfer. I've had that happen a few times where I've had to call back and then you've got to start right over again. And then you get transferred and then you give all your information to the second person and then they transfer you again to the third person. And so often there's a lot of transferring. And at the end of the day, after you've been on the phone for maybe about 20 to 30 minutes or so, has been my experience. You're then said, okay, we are going to sign you up for this residential program. This is the phone number for this program. Go ahead and call and see if they have an availability. And so they go ahead and call. And of course, there is no availability at the day they ask. And so they're told to call back. And my understanding is that you were supposed to call back once a day until you get in. And, or sometimes people will call you. They'll say, okay, or, I've had situations where, we've had people been told that, okay, so-and-so will call you. And, you get a call on your phone and then, they happen to miss it. I miss a lot of calls sometimes. And then when they missed it, they're screwed. Because that's it. That was their chance and they missed their call. They might have been in the bathroom. They might have been not hearing the ring or whatever. And then that was it. So, they either have to call back every day or, they call you on the phone and you miss it. And so I have to say, my patients have a terrible track record of getting into programs. I think just because the system was really built for folks who were a little bit more technology or, phone savvy. And so, that's one battle. And I think, really our program has, when I say program, I mean the Valley Homeless Healthcare Program has done a lot of work around advocacy to really try to advocate to getting the same day access for folks that really want to get into residential treatment availability. I think the other limitation in our county is really the availability of detox beds. And so detox is really kind of the place that you go between kind of, where you are in the community to kind of detoxing from your substance, whether it be alcohol or methamphetamines. And then at that point, after you finish detox, then you move into the residential bed or residential programs. And in our county, we have a serious need for an increase in detox beds. About 1 or 2 years ago during the pandemic, one of the men's residential beds closed down. And so there used to be a male only detox kind of set of beds, and that's no longer. So for men, and to be honest, I think the vast majority of folks that, are, I think the numbers of the men generally, and I don't quote me on this, but I do think that, in general, there's a lot of, a significant number of men that are looking, for residential beds or detox. There is one program right now called Pathways that is available for men. And I believe it's for men and women, but I'm not 100% sure. But anyways, to get in, you have one place. And so if you can imagine, I mean, Santa Clara County is home to millions of people, right? San Jose itself is about 1 million people. And you think about all those other ones and you have one place. And when I say number of detox beds, I don't know the number of detox beds in there, but I want to say it's around 10. And I think the other place that you can go detox is for women, which is Mariposa. And I believe that the number of detox beds they have is under 10. And so you think about the county our size, and you think about the number of detox beds we have, and it is just not enough. And my understanding that I've heard is that there are residential beds available, but not enough detox beds to allow for folks to go into residential.
So you cannot skip a step. You cannot just go straight to residential.
It's a great question. I think as a physician, I've been thinking about this quite a bit. And I think that there are some drugs that you could actually skip because I think my understanding of detox is really around the safety of the patient and their detox phase. And I think, so alcohol use disorder, when you're coming off that, that can potentially be medically dangerous if you are not observed. So I understand the need for medical detox for someone with alcohol use disorder. But, for someone coming off methamphetamines, I actually think that, perhaps there could be some possibilities that maybe they could go straight to residential, but I do not run the drug the drug and alcohol rehab system. I mean, I'm kind of speaking as an outsider, so I'm sure that there are some flaws in some of my thinking there, but I do wonder, and I have wondered about whether or not detox is necessary for all substances. And I say this, I mean, I am not only an internal medicine provider, but I'm also a board certified addiction medicine provider as well. So I'm not kind of saying this off the cuff, but I'm just saying this also as an addiction medicine doctor. I had a medical student work with me this summer, and she called around to different counties, including San Francisco County, San Mateo, and Alameda counties. And by far above and beyond, they have far like higher numbers of detox beds per capita per person than we do in Santa Clara County, which to me is a travesty. We are one of the richest counties in the entire nation, and we do not have enough detoxification beds for folks that are experiencing homelessness or otherwise on Medi-Cal. I mean, it's absolutely terrible.
So if you're on, say, if you're not on Medi-Cal, just have a normal, just like a non-homeless person, right? And if they have drug addiction, they would pay through health insurance, I would say, maybe go to a nice drug, I don't know, treatment facility.
Yeah, I mean, I to be honest, I don't completely know. I've spent my entire career working with folks experiencing homelessness. My view on this side of the fence is that, yeah, I believe insurance would pay a significant amount. Although I do think that, a lot of people do end up paying out of pocket as well. For sort of different kind of levels of facilities. But my understanding is that kind of employer-based health insurance does pay for some drug rehabilitation services.
I see.
Yeah.
And so what about the outpatient treatment for drug addiction, like methadone? I don't know, is that something that's effective today?
Oh, absolutely. So, I mean, I think, again, when folks are experiencing substance use disorders, I mean, I think it's not a one size fit all. There's kind of on one spectrum, you've got kind of residential, sort of in the middle spectrum, you've got maybe kind of intensive outpatient, or you've got other kind of outpatient, and then you've got non-system programs, things like, AA or NA. And so absolutely outpatient is effective. I think that, it's definitely important. And I think it works for some folks. I think, especially for folks that don't want to leave, maybe if they're housed or marginally housed, they don't want to leave, their housing, or, they're working, they may not want to go to a residential program. And so outpatient definitely is more fitting for folks. I think, when you mentioned methadone clinic, I mean, that's kind of another arm of treatment called medication assisted treatment. And so those are kind of using medications to treat different addiction disorders. And those are, especially methadone and buprenorphine, those are definitely treatable and effective means of treating substance use disorders, especially opioid use disorders, those two modalities.
Oh, I see. Great. What about for methamphetamine? So I heard from someone like this is a very potent drug, and then the drug treatment is very different from like, in 20 years ago.
Right. So, I think when you talk about the efficacy of treatment, you look at each condition, right? So, for opioid use disorder, I mean, I think of that as really kind of the gold standard in terms of medication assisted treatment. The opioid replacement therapy, such as methadone and buprenorphine, are extremely effective. They work exactly at the receptor, in the brain that, causes that craving to use opioids. And so it basically replaces, whatever the illicit drug is at that opioid receptor, the mu opioid receptor. And so, when people are on buprenorphine and methadone for opioid use disorder, you have fantastic, outcomes, in terms of retention, going back to work, not going back to incarceration. But when you look at methamphetamine, there are medication assisted treatment options, but they are not as effective when you look at the evidence compared to opioid use disorder. So there are some promising different studies that have shown some potential. I think, one of the most recent ones showed the use of naltrexone and bupropion, and that was kind of a recent New England Journal article in the past year or two, which showed that those two medications combined have shown some benefit in folks with methamphetamine use disorder. But if you look at like the number needed to treat, so the kind of the effectiveness and the number of people that you need to treat, I mean, compared to methadone and buprenorphine, hands down, there is no comparison. I mean, yes, you have a little bit marginal improvement, and some people would say it's a significant improvement. I mean, considering we had almost nothing, yes, it's an improvement, but it is nowhere near as effective. And I think the other evidence-based treatment for methamphetamine use disorder is this thing called contingency management, which is really a process by which folks are rewarded for negative detoxes or urine toxicology screens, and it's sort of kind of a reward system. The state of California had just, through Medi-Cal, has just put out kind of an RFP or sort of an offer for folks to trial this in each county. And so that just came out this year. I think it was a big win for those of us in addiction medicine in California, that we can actually get paid for and pay for ways to have contingency management for folks with methamphetamine use disorder. But again, compared to opioid use disorder, these are not as effective.
I see. For this might be like a naive question. So for someone who is addicted to methamphetamine and suppose they don't receive any medical intervention, any treatment, and then they sleep on the street, what's going to happen?
Yeah, so for folks with any substance use disorder, basically that you're going to sleep on the street and you're trying to get off, that craving is going to start to kick in, and that craving is physiologic, and so they're going to crave that methamphetamine, and so they're going to go and try to find to fill that craving. It is a physical need that is within them, and I think it is hard when you're already on the streets, you're already kind of in survival mode, to have that kind of reserve to be able to withstand that craving. And so, for many folks on the street, that is why often I do recommend the residential treatment option, because that kind of pulls you out of your physical situation and puts you in a community of folks that are supportive and going through the same thing. I just think it's already hard enough to face that kind of by yourself. And so, I think kind of the natural progression of folks, with that substance use disorder is really is going back because of that strong craving.
I see. And then like if they continue to use methamphetamine, is that going to shorten their lifespan, or is that going to deteriorate their health status?
Yeah, I think when you look at folks that are homeless, I mean, there's been a number of mortality studies done in the country, and people experiencing homelessness definitely experience a mortality rate that is significantly lower than the average American. And, the causes of death are often, some are related to drugs, some are related to trauma or accidents, I think so, which bring down that. And so kind of by association, when you have substance use disorder, I mean, you absolutely are at higher risk. We are looking now at some of the biggest mortalities in homeless populations from the drug overdose crisis. So if you look, for example, San Francisco has well-published data that showed that more folks, individuals experiencing homelessness in San Francisco died during the pandemic from drug overdose as opposed to COVID-19. I think, I want to go as far to say that in some communities, there were 0 deaths from COVID-19, yet hundreds to thousands of deaths from drug-related causes. So absolutely a cause for mortality. And it is actually a bigger epidemic than the COVID-19 pandemic was in folks experiencing homelessness.
I see. Could you talk a little bit, I mean, I'm not sure like whether this is something in your field, but could you talk a little bit about the drug court? In the past, before 2014, judges in drug courts, they have a pretty effective tool to compel people who have committed petty crimes into receiving treatment. And today, it seems like we have lost that tool.
Yeah, that's a great question. So one of the programs of the Valley Homeless Healthcare Program is our reentry medical system. So it's the reentry program, which is really intended for folks kind of reentering the mainstream after exiting from the criminal justice system. I feel a little bit out of turn to speak because I do not work at the reentry site. I have heard that there is less kind of drug or court mandated. I don't know the degree to that or the severity of that. I have found it, effective in a number of folks. I mean, again, it's not a one size fit all, but for some folks it was extremely effective. I don't know too much about what's happening now and why. I mean, I know that Judge Manley is a very active judge in drug court in Santa Clara County. And, from my understanding, he's still kind of doing his thing and kicking and trying to knock it out of the park, and has done that his whole life. But I don't know too much about the particular changes that have happened most recently.
I see. Have you heard of something called care courts? I think it's something new.
I've heard that, but I don't know too much about it.
I see. I think it's related. I just looked it up just several days ago. I think it's related to a community-based treatment for people with mental illness, sort of like one stage before.
Oh, yes, the California. Yes, I have heard of that. Yes, the new proposal by Governor Newsom.
Yeah. So like, what do you, I mean, maybe just because we've talked so much about, the negative stuff, like, I'm just curious your thoughts on the future. Like, what can we do to improve the system if you have like a magical wand?
Yeah, well, I mean, gosh, I think, of course, I'm always going to say that, we absolutely need to increase the stock of housing, of affordable housing. I mean, I could just give you tons and tons of numbers of people on the street that just because they were not severe enough or didn't meet the criteria, were not kind of picked or chosen for housing, and absolutely everybody needs to be housed. And so we absolutely need to have more affordable housing. That's a big one. I think, I think it's tough. I mean, I do see a number of folks, I think, because, when you talk about care court, you're really referring to folks struggling with mental illness. And I'm specifically thinking about a few folks that I know, so I'm very closely tied with the kind of the Mountain View community here in Santa Clara County. So one of my roles is that I'm the North County Director, and so I work very closely with Mountain View and the city of Mountain View and a lot of its community partners to really engage with a lot of the folks in the city. And I'm thinking right now of a few folks with severe mental illness. They would love to be housed. They do not necessarily want to be labeled as someone with mental illness or severe mental illness, but gosh, they would love to be housed. I think that some are more open to treatment for their mental health disorder than others. But I think that they could be housed if they were given the opportunity. And so, I think that there is some controversy around the care court. I think some people don't like it because it puts a little bit too much of a push or a mandate. But then on the other hand, I have to say, so my other hat that I do is I work with folks in permanent supportive housing, and I work to actually keep them housed. And I have to say that some of the evictions and the most painful evictions that I've seen are for folks with nothing else but a severe mental illness. And, as hard as we have tried to engage folks with that severe mental illness, I mean, I go to their door, I go and do home visits. I bring the medications with me. I bring the injectables with me. And sometimes folks don't want that treatment. And to be honest, I'm not 100% sure that even if I gave them a shot in the arm, everything would be okay. And I think that's also a myth as well, that, if you could just give them that shot in the arm, then, they're going to go and live a Apple, Google life and make $100K a year. No, I think the medications don't do it all either. And I think, we need to do a better job of engaging those with mental illness and creating spaces that where they can thrive instead of, I think it's hard. I think we do need some mental health specific housing and options. And I think, to me, that's been some of the saddest cases. They have met the criteria to be housed and have been housed, but because of behaviors have forced to re-enter the street. And to be honest, some have died, just having gone back to the street, which is.
So that's really tragic, because they are the ones who the permanent supportive housing was designed for originally by Sam Sambaris, who I also interviewed, right? The chronically homeless. But I mean, like, so why? I mean, I understand they are probably like not being a good neighbor. Maybe they have disruptive behaviors, but like, putting them back to the street, wouldn't that be like exacerbating their health?
I mean, I would say, okay, so I take a step back. I mean, I think when we look at Santa Clara County, I mean, the people that we've retained in permanent supportive housing, we've retained 95 to 96% of people that we've put in permanent support housing. So I'm really talking about 3 to 4% of people, and it's painful for me because I know who they are and I know their faces. But if you look kind of overall, we've done a good job of keeping people in housing. So I think that I think just needs to be made clear. I think mental illness is a varied kind of state. So for example, I'll give you the example of the people that got kicked out, and they should have been kicked out. So one person set fire to her room, and basically the whole entire apartment had to be evacuated. I think they did. I think they needed to get kicked out because they caused risk for an entire building. But I think, what kind of options could we have offered this person? Perhaps we could have offered them kind of a safer environment, perhaps without the use of a stove, or perhaps more in a kind of a communal or group setting where they're a little bit more closely observed. And so that's what I mean is like, yes, I do still believe that folks that have mental illness can be housed. And I think, Dr. Sambaris's work has shown that, and that is, kind of one of the landmark papers that have demonstrated that. But I think for some of these folks that are severe, we need to have some other options. Another option, another example is somebody who was evicted, because they kept hoarding, and they kept bringing all their things, and they couldn't keep their apartment clean, and then things would start coming into the hallways. And, obviously, you would try to kind of work with them and that sort of thing. But, again, I think as opposed to saying, okay, you can't be permanently housed, I think really the solution is, well, why don't we think of housing that would work for them? I don't think that I can completely fix their hoarding kind of behaviors, but gosh, what can we do that would be more supportive? And I think right now what is sad is that we don't have any other options on the table for them.
Yeah, so I guess my last question, sort of like building on what you just said, is what can we provide to those folks who cannot really live by themselves independently in the apartment? So I guess is care courts the next, and then conservatorship is after that? Is that the sequence of approaches that we have right now?
Yeah, I think it's hard. I think, living in America, we have a strong kind of visceral reaction to taking away people's rights, right? I think especially among those that are, struggling with mental illness, and appropriately so. I mean, I think, we have kind of been mistaken as a country where we've taken away too many rights of people in the past. And so, but I think in some cases we've kind of swung too far. And I think some folks, I will say that I've tried to conserve a number of people on the streets because, they're not able to care for themselves. And to be honest, I think they'd be willing, to have somebody kind of take over some of their care. And, the conservator's office laughs at me, and I've not been successful in getting them conserved, and they've given me various reasons why. So I do think that we do need some more options on the table, perhaps kind of to court mandate. I think we would have to be really careful in how we kind of design those policies, because I think we need to kind of, it's that balance, right, between preserving the rights of folks and their dignity and their will, but also I think being a little bit more kind of strong in terms of providing them decent options, and kind of pulling them along in that direction.
Thank you so much. Yeah, that's great. Yeah, thank you so much, Cheryl. This is great. Thank you so much for speaking with me today.
Thanks, Jialu.